Hello everyone, welcome to Module 5, Acute Respiratory Disorders. So we're going to be talking about upper respiratory infections. So this is like your common cold, influenza, things like that. So these can be viral or bacterial, but usually they're viral most of the time. So lots of people get these lots of the time. This is going to be one of the most common illnesses that you're going to see in the outpatient setting. So some of the symptoms you're going to see: nasal congestion, rhinorrhea, sore throat, cough, headache, malaise. You'll see this children, adults. A lot of times the first symptom they're going to have is a sore throat, and then it'll kind of progress to the congestion, to the cough. Usually what I say is the cough is always the last symptom to go away. Treatment: rest, fluids, cough suppressants. If for the sore throat, I usually tell them, to do Cepacol lozenges, saltwater gargles, things like that. Antibiotics, not recommended unless they're sick for 10 or more days. This can lead to lower respiratory tract infection, sinusitis, or aggravation of asthma symptoms. Prevention is key: hand washing, vaccinations, avoidance of others with infections, and avoidance of touching faces. People with children, people around children, children are the ones who generally spread these infections. One thing that a lot of people will say is, my secretions are green, they're yellow, they're brown, they're, fluorescent. The color of the secretions does not determine whether the infection is bacterial or viral. It just means that you have an upper respiratory infection. Still could be viral. So keep that in mind. Pneumonia. You could have a community-acquired pneumonia or nosocomial pneumonia. So community-acquired pneumonia, that means you got it out in the community. Nosocomial pneumonia, you got it in a hospital setting. So one thing you want to know, these are treated differently, okay? So community-acquired pneumonia, generally first-line treatment for this, Zithromax, okay? Nosocomial pneumonia, you're going to have a whole nother pathway for that, okay? So just know your different pathways for your, especially your outpatient pneumonias, okay? Symptoms: fever, chills, cough, shortness of breath, fatigue, headache. However, some of these patients may be asymptomatic. Your pneumonias can still be bacteria or viral. Can even be fungal sometimes, really depends. Risk factors: if they've had a recent hospitalization, if they have a decreased immune function, if they're on a sedating medication, if they recently had surgery, if they have a decreased cough reflex, this is all going to put them at a risk for getting pneumonia. Workup is going to depend on the severity of their pneumonia. It could just be your physical exam, okay, and then they're going to be treated. Or if they have more severe symptoms, maybe they need a chest x-ray, maybe they need some lab work, maybe they need a sputum culture. Prevention: annual flu vaccine, pneumococcal vaccine. This is all going to help in the prevention of pneumonia. The other thing I want to also add is one thing that you should definitely know, especially for your certification exams, is your admission criteria for pneumonia, okay, in the elderly population. Who needs to be admitted for pneumonia? Who needs to be admitted to the intensive care unit for pneumonia? There is a criteria for that, and that is something that they like to put on certification exams. Pulmonary embolism. That's a blood clot in the lung. Symptoms: shortness of breath, chest pain, usually works with inspiration. It's going to be an acute onset, okay? They're going to be anxious, they're going to be tachycardic. Risk factors. So you think about risk factors. They're going to have a family history, okay? They might be on birth control. They may be obese, they may be sedentary, sitting a lot. They may have recent travel. All those types of things are going to put them at risk of a pulmonary embolism. They may be smokers. They may have a previous history of a blood clot, okay? There's different scoring exams. You should know the different scoring exams for PEs. How do you score them? Okay, what does it mean if they get a different if they get specific scores? Okay, low risk, high risk. What do you do with those scores? Treatment. How do you treat these? You could give them anticoagulation. You could potentially have thrombolysis or an embolectomy. They may need an IVC filter. They may need a workup for clotting disorders, especially if you have a patient who has a specific family history of, everybody in my family gets blood clots. These patients are at risk of death, pulmonary infarction, recurrence, and alveolar collapse. Depending on, again, on their history, you need to make sure that this doesn't reoccur because it can be an issue long term. Croup. This is an acute inflammatory disease of the larynx, trachea, and bronchi. Barking cough. They may have stridor, hoarseness, respiratory distress. Viral is the most common cause of croup. Can be bacterial, but again, viral, number one cause. Symptoms generally are going to be worse at night. Usually it's a clinical diagnosis because you can hear it like from a mile away. If you do get an x-ray, doesn't necessarily need an x-ray, but if you do, you could see subglottic narrowing on the x-ray. Treatment generally is going to be humidified air. If it's severe, could have nebulized epinephrine, could have corticosteroids. Cough and cold medications are not recommended for children. Okay, that recommendation went away a while ago. Bronchodilators are only reserved for those who have bronchospasm. So you shouldn't be giving these people, or these children, albuterol. And children may need oxygen if their oximetry is below 92%. Epiglottitis. So this is an emergency. It is inflammation of the epiglottis by H. influenza type B, and it's usually found in a child age 1 to 5. Symptoms is going to be an acute onset of fever, severe sore throat, dyspnea, inspiratory distress without stridor, drooling. Okay, they're going to have severe retractions, hyperextension of the neck. And again, acute emergency. They need airway management, antibiotics, respiratory support. It is really not seen too much anymore because of immunization. And that is a prevention is immunization against the Hib. Okay. Bronchiolitis, inflammation, necrosis, edema of the respiratory epithelial cells in the small airways. It's usually viral, usually RSV. Symptoms. You can see that cough, chorus, rhinorrhea, respiratory distress, fever, decreased appetite, wheezing. This is another common illness that you're going to see in kids, especially, like I said, the RSV is very common. Chest x-ray routine testing is not indicated unless they have severe symptoms or they are hospitalized. Treatment is usually just hydration because the kids are really high risk of dehydration. Antipyretics, so Tylenol, ibuprofen, nasal suctioning. Bronchodilators are no longer used, and antibiotics are no longer used. And infants are at high risk of apnea, respiratory acidosis, and again, dehydration. Foreign body aspiration. So the symptoms for these children depends upon the location. What is the foreign body? Is it coin? Is it food? What is it? And how obstructed is the child? Okay, is it completely obstructed? Is it only a little bit obstructed? So a laryngeal obstruction, rapid onset of hoarseness, croupy cough, unilateral wheezing. They may have a recurrent pneumonia. Tracheal, they're going to have a brassy cough, hoarseness, dyspnea, cyanosis, and a homophonic wheeze. Bronchial, it's going to be mostly in the right lung. They might have some blood-streaked sputum, limited chest expansion, decreased vocal fremitus, atelectasis, crackles, rhonchi, and wheezes. These kids need to be referred for bronchoscopy, treated for secondary infections, and bronchospasm. Bronchitis. You're going to see this a lot as well. Nonspecific inflammation of the bronchioles. Usually it's viral. Could be caused by influenza, RSV, adenovirus, parainfluenza. Could be acute or chronic. Okay. A lot of times you're going to see acute symptoms: dry, hacking cough, burning chest pain, coarse breath sounds. A lot of times I like to assess these people by doing a forced expiratory, listening for a forced expiratory wheeze. I listen to have them take a deep breath in and blow it out as hard as they can. Management, supportive care, okay, analgesia, hydration. Pertussis, that's whooping cough caused by Bordella pertussis. Classic cough lasts 6 to 10 weeks, and it's also called the cough of 100 days. Their symptoms: characteristic cough, which is the inspiratory whoop, and tachypnea. Treatment: if you're going to test them, it's best during the earliest stages. And the treatment is a macrolide antibiotics like Zithromax, and an alternative is Bactrim. Prevention is obviously immunization, and it can be very dangerous in young children, causing apnea, seizures, encephalopathy, and death. And there's some references for you.